Thank you so much for being here for Think Science. I'm Nathan Cohn with Texas Public Radio. And at each of these talks, our goal is to get you in and out in an hour, having learned a little bit more about the subject at hand. And whether we're doing it virtually or in person, that is the same goal of these Think Science presentations from Texas Public Radio that we do on a quarterly basis. And our focus today is on keeping clean during COVID-19. We're going to be talking about sanitization, both for yourself and for your personal space, and for businesses. And today's presentation is made possible by San Antonio Vascular and Endovascular Clinic and Xenex Disinfection Services, and by you as a supporter of Texas Public Radio. Our moderator today is going to be Bonnie Petrie, who's Texas Public Radio's bioscience and medicine reporter. And when it comes time for the Q&A portion of the panel, if you would type your questions in the chat room, I'll be able to relay them to the panelists. And with that, I'm going to turn my camera off and send it over to Bonnie Petrie. And if you are not muted and not a presenter, then please go ahead and mute yourself. Thank you.
There we go. There's the mute. Hello, everybody. Thank you for joining us. Again, this is Think Science, Keeping Clean During COVID-19. We're going to talk about minimizing the risk of infection in closed spaces. How about when you touch things? What do you need to clean? How much? With what? I don't know if you guys watch Saturday Night Live, but in a recent sketch, they talked about washing a bag of Doritos. Do you really need to do that? Do you need to wash your chips before you eat them? We will find out. We'll talk to the experts. And here is who is with us today. Dr. Mark Stibich is the founder and chief scientific officer of Xenex. Xenex is a disinfection system that makes patient care areas safer by reducing microbial contamination. He'll elaborate on that in a minute. Dr. Stibich received his doctoral training from Johns Hopkins. Actually, he apparently is a tinkerer. He likes to invent things and holds over 80 patents. Also joining us today, Monica Pierce-Charlton, who joined us on a Petri Dish podcast a couple of months ago. She started her career in the lab as a lab scientist, specializing in microbiology. She holds a master's degree in business and healthcare management and is a certified in environmental and prevention. I hope everybody's muted. It looks like everybody's muted. Thank you. Anyway, Monica Pierce-Charlton is the Director of Infection Control and Prevention at Children's Hospital of San Antonio. Thank you both so much for joining us. Let's start with you, Monica, if you'd like to talk to us a little bit about what you know and what you do. Thank you so much for joining us.
Okay, let's see. Your entire screen. Okay. Sorry, I'm trying.
There you go.
Can you see my screen?
I can.
Okay, let me pull that up. All right. Oops. Sorry guys, I'm having technical difficulties, but we're gonna get there. That was me. I reviewed it before I got on just to make sure everything was in the right spot. Okay. So I was going to tell you, my name again is Monica Pierce-Charlton. I'm the Director of Infection Control at Children's Hospital of San Antonio. And I just want to tell you a little bit about what an infection control practitioner does on a normal day. And then also, you know, what we're doing in the middle of the COVID pandemic. These are some of the roles that an infection control practitioner does on a daily basis. One of the big roles and main goals or roles that we do is educate, teach, and train our associates that we work with. We also do surveillance. We also investigate outbreaks. We're the hand hygiene champion for the hospital and all of our facilities. We also are very involved in compliance. We do research. We're also involved in antibiotic stewardship. We evaluate products. We're very involved in construction, waste management, and we also help develop and implement policies. Some of these things we may not think about infection control in some of these areas, especially construction. Those are one of the areas that when I first got into, if you had told me I would be looking at construction and containment, I would have told you, what? I've never heard of that. Okay, one of our big roles in a hospital setting, our healthcare, is hand hygiene champion. We follow the guidelines set by World Health Organization before touching a patient, before a clean or aseptic task, before touching a patient. After touching a patient, after touching the patient's surroundings, and after contact with blood and body fluids. And we all know during the COVID pandemic that hand hygiene is very important in controlling this infection and keeping it in check. And hand hygiene is one of the single most effective ways that we all can help prevent infections. 3 things: it's easy and it's inexpensive and everybody can do it. We all should take charge for our own health and preventing infection. These are some of the other duties that we do as an infection control practitioner. We are involved in, of course, education and training. Our target population are healthcare workers, patients, their families, visitors, and the community. We will go out in the community and talk to schools and healthcare organizations that we're affiliated with. Many of the activities that we do are isolation. Here are examples of some of the signs that we would use to help isolate our patient and prevent infection transmission within the hospital. We also do plenty of auditing, EOC rounding, and checklist and education and auditing compliance. These are some of our other duties that we do. When I talk about surveillance, not only are we, surveilling within our hospital and preventing infection in our hospital, when we do detect infections, these are reportable events that we have to report to different levels of government, whether it's local, state, or national. And when we do detect these infections, we also get with the teams to try to figure out how we can prevent them in the future. We work very closely with pharmacy for antibiotic stewardship, and then also help the teams with researching best practices for safe patient care. We also evaluate products within a hospital. Anytime we change products or need to evaluate a product that might be malfunctioning, so that's we help the teams and what's called our central supply with those products. Operational planner, of course, we all have a budget, and then our construction activities. The Children's Hospital is ever changing and expanding and growing to serve our community, but we want to make sure those activities are safe. And to be an infection control practitioner, the required skills is a background in healthcare, whether it be nursing, microbiology, public health, epidemiology. That's where we usually pull from the pool of infection control. Knowledge in bedside care. You have to have really great communication skills, computer skills, and more recently, within the last few years, needing to know a lot about statistics and knowledge of how to read statistical analyses and knowledge for process improvement. Oh, look, I misspelled knowledge. All right, infection control during a global pandemic. So not only are we doing infection control normally on a day, now we're also doing things to help prevent a global pandemic or keep our teams educated for a global pandemic and keeping them safe. Every facility will have a pandemic diseases plan. And what you do when this starts to happen, you get it out, dust it off, and you might have to make some revisions or add some items to it. You need to remain very flexible during a global pandemic. We know that during COVID, we've been getting new recommendations from CDC on a regular basis, especially in the beginning. We also develop simulations. So when we knew, I'm in the San Antonio area, and when the Diamond Princess cruise evacuated their Americans here, we had to make sure we were ready in case we had any children show up in our hospital. During this time, we've had to make develop easy to read and access job aids for frontline workers. So not only have we created what we're calling a COVID or emerging pathogen binder for each of our departments that they can easily access, and we're continually updating those, we've also put it on our intranet so that it's easy for them to access as well. We keep current with all the updates and changes, work closely with our incident command. We're involved in many committees that are going on in the hospital right now with all the different units. We are communicating closely with our local, state, and national reporting agencies. And by far the most important for our associates to feel like they are we're providing safe guidelines for them is to communicate, especially as things are changing. And this is one of our sayings around the hospital is not today, COVID-19.
Monica, let me interrupt you just a moment there. Do you have a button on your screen that says share screen?
Oh, did I go through that and y'all did not see it? I'm so
Yeah,
sorry.
push that button right there and let me see what's going on.
Let's see. Well, it does, but it doesn't light up for me. It's a gray.
You push that button and it should light up because you're a presenter right now.
No, it's not lighting up.
Okay, all right. Well, we'll take your slides then, and we'll be able to add them to the web presentation on this as we
Okay.
post it later on.
Yep, I'll send them to you.
It
Great.
was great anyway, very informative. Thank
Oh,
you.
I'm so sorry about that, guys. Someone should have stopped me sooner.
It was fine. It was fine. Okay.
I don't need to be the fact.
Okay, did anyone have any questions?
Oh, wait.
Because I got to the
We'll
end.
get to questions. We'll get to questions after.
Okay.
Let's get to Dr. Stibich. Tell us about what you do, what your work is.
Sure, and I'm going to give this. Oh, it's complicated to share screen. Let's see if it works. Not now. All right, so I will describe the pictures that I have coming up here. But what I want to talk about first. So our work is disinfection. The robot, but I want to talk about COVID and surfaces because I think there's some confusion out there. And so the first picture I have here is it's in Moscow and it has these trucks that are driving.
Again, what are they working on? What is the service they're using?
It's not Zoom. It's GoToMeeting or some other
yeah,
one.
so there's just a little noise there. But I'll keep going. So it's this picture of these trucks driving through and
it's funny, it's been months, people still don't.
everywhere.
Hold on, let's go for it. Let's see if we can figure this out.
Yeah,
Nathan,
sure.
are you there, Nathan? Hello. And it's quiet now, so maybe we should just go for it. Let's go for it, Dr. Stibich.
Let's go for it. All right, I think I figured out the screen sharing thing in that little moment. Let's see if that works. No. It wants me to restart. Okay, I will keep going. So you see these trucks, and you saw these early in the pandemic, like people in Italy spraying courtyards and all that. That's kind of crazy, in terms of thinking about COVID and COVID risk to be disinfecting like outside spaces. And then a lot of the communications now are trying to reassure people that your Grubhub or your Uber Eats package is
trying to get over to the text and
you don't have to be disinfecting your mail and all these things. And so what I want to kind of throw out there for everyone is that all surfaces are not equal in terms of the COVID risk. So if you ever read or see anything, surfaces are safe,
$35.
don't spread COVID.
Not including tip or whatever.
You got to really
This is a different booking service, so I didn't know if I understood exactly what I was paying.
probably a lot safer than the materials used in in a hospital room when they're doing an intubation of a patient. All of those surfaces are quite high risk. And so we really have to start getting a little more nuanced when we think about surfaces. And there was a study that came out just a few weeks ago in October that really looked into this in a great way. And they looked also at the effect of temperature. But what they really found is that, at colder temperatures, it can be up to 28 days, viable SARS-CoV-2, the COVID virus, can survive and grow back in a Petri dish. And so we see a lot of variance in terms of the types of surfaces. And these surfaces like stainless steel or plastics or paper, they all, depending on the temperature, can last hours, and in some circumstances, even weeks, virus can persist on them. So when we think about, is a surface a risk? We want to really think about the context of that surface. What is it? Who was around there?
Because you've been doing so much exercise, you might be feeling weaker?
Might they have sneezed? Might they have been depositing virus on those surfaces? We know that infected people do contaminate the environment they're in quite widespread. So that's something to think about. So again, when we hear surfaces are not risky, it's really stepping back and saying, what's going on with that surface? And what are the likelihood of a virus being deposited on there? And that's really what we need to consider. What I do is I'm an infectious diseases epidemiologist, and I started a company almost more than 10 years ago now. It's based in San Antonio, Texas, called Xenix. And what we do is we have a device, a robot, a germ zapping robot that can be brought into patient care environments and now non-patient environments as well. And it basically zaps the room. It disinfects the room. It takes about 5 minutes. How we do that is it uses a high power or high energy UV light that doesn't naturally occur on Earth. And because of that, the microbes and the viruses haven't evolved defenses to it. So we're able to quite rapidly deactivate those and reduce the amount of risk an environment can bring to patients and workers and visitors and residents and whoever else might be around. We're primarily deployed in hospitals. We're in about 700 hospitals in the US. But we've also now, because of SARS-CoV-2 and other reasons, we've moved into hotels and hospitalities and even into schools and professional sports. So there's just anywhere there's a concern that the environment might be causing a risk, we're able to come in there and rapidly reduce that risk.
That's very, Star Trek.
You.
It doesn't seem, it doesn't seem like it would work. So how does it work?
So so we use it's a light, so it shines onto the surfaces in the room. But what it does is we know UVA and UVB. We're familiar with those. The ozone layer filters out what's called UVC. So these are higher energy wavelengths of UV, of ultraviolet light, and those will penetrate the cell walls or the shell of a virus, and they will basically mess with the DNA or RNA inside. So it's causing enough damage to the information of the organism that organism can no longer replicate. And we're also, because we use even additional high energy wavelengths, even higher than some of the other ways of producing this, we're able to cause actual structural damage to the cell and essentially lyse it or crack open the cell wall, all with just light and photons.
Maybe that's why the president was talking about trying to get light inside the body.
Yes.
Right?
Exactly.
All right. Okay, Monica, so what can you tell me about, I'm sure a lot of the people listening right now are, thinking and wondering about, if you've got several people in a room, how to keep people from infecting each other. So what are the risks in, say, a classroom or Thanksgiving dinner or anything like that?
Yeah, so those risks, when you're inside in close contact with people outside of your immediate household, your risk will increase. So if you find that you cannot social distance, it would be very important to wear a face covering when you're in those situations. Better yet, maybe try to have these gatherings outside where you can social distance and have space between each other. The recommendation is to stay within your household, or if you can't, to social distance or wear a face covering and hand hygiene.
So I'm doing a bubble Thanksgiving. It's me and my daughter. So this is theoretical. If I had a bunch of people over, if I followed everybody around with Lysol wipes, would that be useful in any way?
Probably not, because you're going to be speaking to each other. If you're not wearing face coverings and you're in close proximity, you will be spreading droplets. So those droplets are airborne and you can spread it that way. Sure, you can wipe your surfaces down, but realistically, you probably cannot follow people around your whole gathering wiping surfaces.
So you, Dr. Stibich, touched a bit on fomites, which are those non-porous surfaces, right? Like my desk. What you said, they're not all created equal. I remember at the beginning of the pandemic, a very respected infectious diseases doc told me that kids could probably play on the playground because the sun would beat down on the, on the playground equipment and kill the virus. But playgrounds have all different kinds of equipment. Houses have all kinds of different surfaces. So tell me about how surfaces are not created equal, which ones we need to worry about.
So, in the household or, in residential, so the bathroom would be one of the first surfaces I would be most concerned about. We know that the virus can be present in fecal matter, and it can be viable in fecal matter. And when there's the excellent studies of they're called the toilet plume. When you flush a toilet, virons and everything else are like accelerated up out into the air, and they're spreading all over that bathroom surface. So that would be one area that if someone were asymptomatic, they use the bathroom, they flush the toilet, hopefully, and that would then potentially spread virus at potentially infectious levels in that area. Less so are you going to be worried about, your surfaces out in the main house, from a household perspective. So if I were to Lysol something when all my guests are coming, I would start with the bathroom as the highest risk surface. In terms of the playground, so that UV, that sunlight, that's UVA and B, it works roughly in a similar manner to our germ zapping robot, just a bit slower because the intensities and the energy is less than that. And overall, I really want to be able to say like playgrounds are safe, except the children lick things. Like I have kids, they're past that stage now, but you do have that with the infants, the hands and the mouth and all that. And if someone had just literally licked a railing and someone else touches it or something, that does pose a risk. Overall, if the playground's been unoccupied for a few hours and then you're the only one who's playing there, that's going to be fine. Those surfaces aren't going to cause risk. And then we get into any surface where someone who may have had maybe either asymptomatic or symptomatic with the virus in them, the surfaces they've been around, those are going to be contaminated, and we should figure out how to disinfect those surfaces.
I'd like to start taking questions, and I don't know if anybody has written any in, but you can now if you'd like. While we're waiting for that, I'd like to ask Monica, so obviously you have a sick population, a COVID infected population at the hospital. So how do you protect the uninfected from the infected at the hospital?
So when we have a COVID positive patient or one who's suspicious and being tested or a PUI, we will isolate that patient on what we call airborne in contact. And until we get a positive result or a negative result, that patient will stay on that isolation. If the patient is positive, they will continue that isolation, their hospital stay if it's under 10 days. If the patient has mild or moderate illness, the patient will stay on isolation for 10 days. If they're going to continue their stay, they can come off of isolation as long as their symptoms have resolved and they have been fever-free for 24 hours without fever-reducing meds. If a child has moderate to severe disease, there may be a need to keep that patient on isolation a little bit longer and for up to 20 days. There is evidence showing that patients over 20 days, even though they may be testing positive for COVID, are no longer infectious. Many people who have contracted COVID are testing positive for up to 90 days. And our personnel will wear PPE. They will wear N95 masks. They'll wear eye protection gowns and gloves during COVID care.
That's going to be so hard for the kids.
It is. I mean, it's hard for anyone right now, but kids, it's hard for everyone. And just a child being in the hospital in general is difficult for a child. We're fortunate in that we are able to allow a guardian with that child. I know in the adult facilities, they are not allowing other caregivers in unless it's some sort of emergent situation or maybe a dementia where the caregiver would actually be helpful in their care while they're in the hospital. So we do have a guardian there who's able to help us help care for that patient. But it's difficult when a child's in a hospital no matter what. COVID just makes it more difficult.
Yeah, that's definitely true. Nathan, hi. I see your face.
Yes, thank you. Prior to today's conversation, I was speaking to somebody and they wanted to know for today from either one of you some best practices. And it's one of those recurring questions that we've heard, and it sounds like a dumb question, but this is something that we all need, like, do we wear gloves, all the time? Should we be wearing gloves when we're at the store? Should we be, using that in our regular practice, or is simple hand washing the best thing for us to do? And I'm thinking, Mark, about your example of kids licking surfaces, when I say this.
Well, so gloves, I think go ahead, Monica, please.
Well, I was going to say I'll answer it, and the recommendation is not to wear gloves all the time. And several reasons for that. I see it in the grocery store, and my thought is when your fruit, your produce, your products that come in, they aren't always bacteria free. So when you're touching items with gloves, and then you touch another item with those gloves, you could be transferring germs everywhere. And not only that, I see people who are wearing gloves, they touch their face, they touch other parts of their body, they're pulling their wallets out, touching their purses, opening their car doors, and now you're just spreading more germs. Also, wearing gloves prevents you from actually doing hand hygiene. So people who wear gloves are not performing hand hygiene as often as they would if they were not wearing gloves. So the recommendation is not to wear gloves all the time.
Yeah, that's totally accurate. And what people don't realize is you can actually do hand hygiene while you're wearing gloves. Like just because you have gloves on doesn't substitute for any of the hand hygiene rules. You know, because you can transfer things. And as Monica said, there's some excellent videos. There's this nurse on YouTube, that's a great video where she puts fluorescent dye on her gloves and just like does normal things. She touches her phone, like in the end she's just covered. So like she's just touched everything while wearing gloves. It doesn't make you any safer. And in some ways that some organisms may actually transfer more readily with gloves on than with the natural oils of your skin that have some ability to trap organisms. So gloves don't replace hygiene. That's for sure.
Yeah, well, and I would also caution hand hygiening gloves because that alcohol could start to break down the gloves, and now your gloves could break and not perform like they're supposed to.
Sure. Thank you. Yes. Yeah, it depends on frequency.
I feel like some of this stuff is what did I read in the New York Times article? Hygiene theater, you know, stuff that feel better but doesn't really protect you. So, you know, the basic recommendations are still simple. You know, wear a mask, keep your distance, and soap and water, baby. Right?
The one question, if I'm like when I'm consulting with people or nursing homes and facilities, the question I like to ask is, and you can ask this every day, is like, what is the riskiest thing I'm going to do? Like, think about your day, where you're going to go, grocery store, you're going to go, whatever you're doing. Ask yourself, what's the riskiest thing I'm going to do? And then just don't do it. I mean, that will help a lot. If you do that every day, eventually you'll be getting to some pretty good practices. But yeah, just don't do the risky things. I think by now, hopefully there's been a lot of education. We know or sense what they are. And they really are indoor gatherings, especially with poor ventilation, are pretty much being shown to cause the most transmission.
So I definitely want to talk about ventilation in a minute. First, I want to ask Heather Hansen's question, which is, what is the current knowledge on how long SARS-CoV-2 lasts on different surfaces like clothes, plastics, metals? Who'd like to hit that first?
Let me pull up the slide. I have that slide here. And so the current knowledge is here. Glass, paper, polymer, and stainless steel. And I'm going to do a 30 centimeter number. So the half-life, the time in which, at 30 degrees centigrade, we're looking at stainless steel at least 12 hours, 14 hours for paper, 32 hours for paper, 10 hours for glass, 11 for cotton. Vinyl is at 1.4. That is the half-life. So half of the virus at those times I read is gone. In order to get to all of it, then we add days and even into weeks at different temperatures. So some of those surfaces can survive for 3, 7, or 14, even almost 21 days at 30 degrees centigrade. What you need to think about though is so the different types of surfaces, in order for that to be infectious, there has to be enough of a deposit of the virus there. We call it the viral load. And so when you're considering surfaces, that's another factor to think of. How long does virus survive on this? We know that pretty well now. But what happened to the surface? Like, what is the probability of someone, and it could be an asymptomatic person having deposited some droplets on the surface. And then what are you doing with that surface to get those droplets into your eyes, ears, nose, or maybe not ears so much, eyes, nose, mouth. So really thinking about all of that context to evaluate a surface risk.
All right, here's one for you, Monica. Are face shields without masks effective?
They're more effective than nothing at all. But I would say that wearing a mask is much more effective than a face shield. There are some people who have a hard time tolerating a mask. especially some of your younger or developmentally disabled folks, that having something on their face is hard. So a face shield will help them. But remember, a face shield is still kind of open. It's not close to your face, and being a droplet organism, if there's a cough, depending on how someone's around you, it could get up through the face shield. So wearing a mask is your best protection.
That question was from Todd P. And I'll tell you, when I see people with just face shields, I know it's better than nothing, but it scares the heck out of me, because the virus goes under, you know, it can go through the sides. I mean, that's the thing, right? I talked to a doctor last week who said even masks, you should wear one with metal on the nose, because when it form fits to your face, it keeps the virus from getting to where it wants to go, which is your nose. So
well, and I'd also like to point out that face coverings, right now, when we think of face coverings, we're thinking more about source control. It will help prevent droplets from getting around the mask on the inside, but also masks right now are mainly about source control. So if everybody's wearing a mask and controlling their source, then we're helping each other. The only masks that truly would help prevent organisms coming through it are going to be a medical mask, and many of those are being reserved for our medical professionals right now. And I also want to point out that a face shield is more about eye protection than respiratory protection.
Well, then somebody else, Amber asked, should we be wearing eye protection over our glasses?
So glasses aren't considered true eye protection, because debris can get around the glasses. I don't think being out in regular public, we need a universal eye protection. It's being transmitted by droplets, but many of our patients aren't getting it through their eyes. Now, healthcare professionals, we are wearing universal eye protection while we are taking care of our patients, because that's a different type of setting. But I don't think that it's a recommendation that we should be wearing eye protection on a regular basis out in public.
That's part of personal protective equipment, right?
Yes, and if someone wants to wear it, more power to them. Right now, covering your nose and your mouth is one of the most important things you can do to protect yourself and others.
So I think I was thinking while we're talking, because obviously here, if somebody coughs on you and gets droplets on your glasses, obviously they're not protected. So you take them off. That's why you wash your hands all the time, right? So if you take your glasses off, before you touch your face or anything, wash your hands and wash your glasses. So, right?
Well, and that would be another recommendation. Touch your face as little as possible. If you're not touching your mouth or your nose, you're not going to be introducing any pathogens with your hands.
So, Monica, you talked about source control, and both of you can weigh in on this. Mark, Beth Saltzman says, I've read N95 masks do not do source control. They only protect the wearer. So what are your thoughts on that?
So I think what he might be referring to is the N95 mask that has a valve. The valve opens up and allows the source out somewhat, but when they breathe in, the valve closes. So if you're using an N95 without a valve, it definitely is a good source of source control.
Mark, do you have anything to add there?
No, I totally agree. And what I think is kind of hard for people is this is all about probability. I'm a statistician, I'm an epidemiologist, so I think in probability. So should I wear glasses or not when I go to the grocery store? Well, if you wear them, even regular glasses, that's, if someone does sneeze or cough, they will reduce the probability of viruses coming in. Is it better to have goggles? Yes. Do you need them at all? It's all probability. Like a face shield by itself, I think I read is about a 5% reduction, in terms of the amount of flow of droplets that come in and out as you breathe, because you're creating positive and negative pressure as you breathe, and things are coming in around the side. A mask is better, a face covering is better, a mask, and it's all about trying to manage like these multiple variables and the probability of each one contributing to your safety, and then also, as Monica said, the source control or the safety of others. And that's really tricky. But I think going after that really high ones, to start with, universal masking, that's source control, It does protect the individual wearing somewhat, but it is primarily a source control thing. Not gathering in indoor spaces. There are certain really basic things we can do that we know that are higher risk things. And then getting into, should my glasses wrap all the way around? Is it better to have this or that? We can make ourselves crazy also. So it's about, it's risk and probabilities.
Yeah. Well, and if we're performing source control, the risk of eye contamination goes way down.
Exactly. Yeah. So if we're doing some of these other basic things, then those risks and probabilities drop.
Yep.
Okay, so anybody else who has questions, feel free to type them in the chat. But let's talk about ventilation. Monica, when we first met, because now we're all meeting online, we were talking about classrooms and ventilation. Let's talk about ventilation. I interviewed a friend last week who's pregnant. She had her family visit. Finally, she couldn't take it. They social distanced, but she had about 1 billion different kinds of air filters in her house, in addition to masks. And like, she was very serious about it, which I loved. But tell me, what can help in classrooms or in different settings in your house as far as ventilation goes?
So when we talk about ventilation, it's having filtration definitely plays a role and can help. If you have several people in a room, even though that ventilation is helping to turn over that air, you still have those people in that room who could potentially be exposed to a risk because they're all in the room at the same time. So ventilating throughout the day helps, but isn't going to prevent someone from getting ill. In the hospital, we have what are called negative flow rooms, and we have the patient in that room. And what that means, negative flow, the air is coming in under the door, so there's not airflow out, and there's just one patient. It really wouldn't serve a purpose to put a patient in there who needs negative air and then have another patient in there. Because even though we have a negative room and we're protecting the environment, now there's another person exposed in there. So I kind of look at it that way. Even though we're turning over the air, there's more than one person in there and everyone's still being exposed to the air. Does that make sense?
Mark, do you have?
Yeah, so when we're evaluating spaces, so I've consulted on some films and things where they're going to shoot in an indoor space, they have to. One thing we look at is the amount of carbon dioxide. So outdoor carbon dioxide, the parts per million is about 400. That's as ventilated as you can get. If you have a lot of people together and you measure the carbon dioxide and you see it going up above 600, 700, 800, that tells you that that space has all indoor spaces are going to have a problem no matter what they're measuring. As Monica said, there's always risk there when you put the people together. But as you see that number going up, you know that there's that's how you can define this is a poorly ventilated space. And that can be improved by some simple things like opening windows. Then you'll see that carbon dioxide number come back down. You can also have various air scrubbers, air filters that will come in and start recirculating, cleaning the air. And so if you do have to go into indoor space, this is an important consideration to think about, like what is happening with the air in the space? What are the number of people? How rapidly do we circulate the air? Studies have shown airplanes, when in flight, because of the air circulation system, are actually not as risky as we probably initially thought they were. Everyone's also masking, but because the air is circulating, I think it's like 22 times an hour or something. The virus level doesn't build up to get to an infectious dose as easily as if that weren't on, the circulation's on. So it's a consideration, especially as people come back to work and think about their indoor spaces.
Monica, if I were like dead set that I was having grandma come over for Thanksgiving and I'm just doing it, if I opened all my windows and had 15 fans, and is there any way to make it safe?
Sure, you could stay six feet away from grandma the whole time. It would be a safer environment and wear your face coverings. That would make it safer for grandma.
All right, great. So we just got a question here, Heather Hansen. Are there any documented cases of people contracting COVID via surface contamination? Have you heard of any in the hospital environment?
We have not. We have not heard of a transmission that way in the hospital.
Mark?
So there have been indirect virus transmission studies. CDC released one. These are out of China, where they were able to track to what we call indirect virus transmission, so from surfaces or other types of contact than aerosol. I mean, part of the issue here is those studies, you know, in terms of, I don't even know how we would do that study to show where infection is coming from in a setting. You know, we just see the infections happening. And can we say with certainty it's from this way or that way? Not exactly. But there are published studies that show what we would call indirect virus transmission.
Anything to add on that, Monica?
No, I don't have, and you're right. I don't know how we would prove that that folks have contracted COVID from a surface,
Right.
Especially when we could possibly be having exposure in general out in the community.
Sure.
Yeah, it's not like a silly question to say, is there a contract tracing
You can't
version
of
of surfaces?
Sure.
No, because the risk would be in parallel. So if I'm, you know, if I'm getting surface contact, I'm probably there's also air contact. And what to the level of virus threshold to cause an infection? I don't know how to do that study in human, like maybe you could do a study in mice, but I don't know how to do that study in humans because exposure, people will be exposed to both surface and air.
Yeah, when I asked the question, I didn't even think about how difficult it would be to determine, you know, where a person actually picked up the infection. Before we get to our next question, and feel free, people, to type a question. I read that restaurants and things are putting those plastic dividers, and I'm going to shoot this one at you, Mark, between tables and stuff. And of course, the vice presidential debate had them, and I've read they're useless. That's another example of hygiene theater. What are your thoughts?
So I think it's tricky because you know, you're going to concentrate the droplets of some people and separate droplets of other people. So if I'm eating, you know, whoever I'm eating with, if we're in this bubble, my air circulation is going to change on that. So if that person's asymptomatic, we have our masks off, we're within 6 feet. That's actually magnifying that risk for the people at the table. It may be minimizing the risk for the people at the next table somewhat, but air flows. Like it's not a direct, you know, it'll block a sneeze, but the droplets can float. And there's some studies that show there's an aerosolized transmission as well, which means that the virus can remain suspended in the air. In which case, I'd be concerned that these, without really evaluating how these barriers are going to work, you're altering the airflow in that space and potentially concentrating droplets and increasing the risk for the people maybe at the same table. So the probability right now with the positivity rates as high as they are, that if you're going out to dinner, that someone in that restaurant is asymptomatic is quite high. And so whoever that person is eating with, they don't know they're infectious. Everyone in that bubble is going to be at quite high risk.
Yeah. Well, and also I'd like to add that something else you got to clean after your patrons leave, and your servers. You're also putting your servers at risk when you're talking about changing the airflow whenever there's bringing food and drinks to the table.
The servers entering into that bubble to clear,
exactly.
They're going to be at very high risk because we are concentrating.
Yeah, and I just want to be clear that right now, with positivity rates so high, as you mentioned, Mark, and just basically the virus surging everywhere, maybe not with restaurants right now, maybe just stay home.
Yes, please.
Yeah, right? Stay home right now, at least for a little while. And I know that's terrible. I almost said it not as nice word, but and it's difficult.
What's the riskiest thing you're going to do, and don't do it? Not only for yourself, but for everybody else too. We've got to stop it.
Yeah.
And restaurants, unfortunately, are fairly risky, especially now that we have to move into indoor dining. Outdoor dining had a bit of a different risk profile, but as it gets closer, it gets more challenging.
I saw a crazy video on CNN where they use blacklight to show where something can go if you're just sitting there, not even talking loudly, just, you know, handing, and that's fomite, right? Handing dishes to people or handing salt and pepper to people. So on the level of risk, how risky is eating with people? And Monica, we'll start with you because Mark took the last one.
Like Mark said, with the positivity rate being as high as it is, it's risky to go somewhere where you are going to take off your face covering and eat. It's risky. It's a risky activity to go to a restaurant right now, especially, before it was 25% and 50%, and now we're up to 75%. So you have almost a full restaurant potentially that people may not be a full 6 feet away from you. And we're taking off our masks and we're eating and drinking and speaking, and it's a risky activity right now. And I really feel for the restaurant and bar owners right now because of that.
Yeah. Before I go to Mark, I want to remind you, please ask any questions that are on your mind. Mark, your thoughts?
Yeah, so in exposure, there's different definitions of exposure. Some states have separate definitions. CDC says in exposures, a cumulative 15 minutes within 6 feet for in a 24-hour period. They don't really say whether you have the mask on or not. They're just talking about like being in distance. So certainly anytime you have your mask off within 6 feet of another person who's not in your bubble, who's not in your household, that's an exposure. And really think about your day and think about how many exposures you might have. So checking out at the grocery store is not an exposure. It's less than 15 minutes with the cashier or the other person. But being in a car with someone driving across town is going to take 15 minutes. That is an exposure, even if you have your masks on. Eating dinner with someone is an exposure. And so think about your day. This is what I'd advise you, and think about how many exposures you have and have less. Just figure out ways to do those things differently. And the same thing with Thanksgiving. No matter what you do, if you're within 6 feet of another person who's not in your bubble, that's an exposure.
Yeah, and just to be clear, when we say bubble, we mean people in your household.
In your household, people you have audit with. Yeah. But there's all sorts of new terminology. But yes, people in your household.
Monica, I don't think people have talked enough about what Mark just touched on, which is the amount of time you're with someone matters. Can you tell us about that?
Yeah, and that is a newer definition about cumulative time of 15 minutes through over a 24-hour period. And I do believe that they do say without wearing some sort of protection. And maybe I'm thinking about it from a healthcare provider perspective, because when we talk about exposures, whether people can come back to work, what kind of exposure they've had or not.
In 95, again, it varies by state, so I'll let you talk.
Yeah. No, and I get it. Everyone has a different definition of it, and whenever we use it, have you had your mask on or any sort of face covering during that exposure? Because for us, it depends on if they can come back to work or not. And I'm sorry, Bonnie, I've forgotten the question.
Sorry, I was talking about time matters, right?
Yes, time does matter. The more exposure you had to a person without any sort of protection, it matters. We've had incidences where we've had potlucks within our system, and everyone's been exposed, and that's how we've contracted it. Many of our exposures in our hospital have been from community exposure, and people are doing a great job in the facility of protecting themselves from patients or potential PUIs, but when they get out in the community, they get a little more relaxed. So definitely time of exposure plays a huge role in whether you're more at risk of contracting COVID or not.
I think people like to know why things are true, at least the kind of people who show up for a Think Science. So why is it true that the length of exposure matters? Monica?
Well, you go ahead.
You need a certain amount of virus in order to trigger an infection. A small amount may not, depending on your immune system and other variables, may or may not cause an infection. The more virus you're exposed to, the higher the probability that will turn into an infection.
And also the person, if someone's asymptomatic, like you said earlier, their viral load is not as high, and if a longer exposure to that could potentially put you at risk. And then if someone is, have a more severe disease and they think they may have allergies in that exposure, because right now it's allergy season for a lot of people. And sometimes it's hard for them to determine, is this headache due to my allergies, or, is it something else? So the time, the viral load that you're able to take in during that time plays a huge role.
I hate this virus. Let's be clear about this. But it's fascinating to me in that when you're asymptomatic, your viral load is higher and you're more likely to infect people. Whereas like Ebola, other viruses don't work like that. You have to be sick to infect other people, right? I think that's interesting, and something important for people to know is that there's more virus earlier. Mark, I see you want to talk.
No, I actually have it's kind of a jumping topic a little bit, but I have a question for Monica, if I could.
Oh, go ahead.
And, so we get this, this comes up in workplace a lot and some of our customers. So I call it the person C problem. So person A is the person who has COVID. Person B is someone who's clearly exposed to them, whether they're in the same household, they went to dinner, they're in a car, whatever it was. Person C is in person B's household, for example, or someone who's exposed to person B. Person A obviously has to quarantine, they have COVID. Person B should self-isolate. They have, because they had an exposure. It's person C that's always a challenge in terms of, can they come back to work? Should they go get tested? Like, this comes up nearly on a daily basis.
It comes up all the time.
and I'll tell you, it's come up several times with us too, and trying to advise whether an associate can work or must quarantine, and that's kind of like the third, what we call it, like a third level exposure, if you want to, if you feel if that's what we would say, but we don't consider that third person exposed. If they were exposed to person A, definitely a possible exposure, but not with that intermediate, unless that intermediate showed some sort of symptoms or actually tested positive. We wouldn't consider the third person an exposure.
Thank you.
I have a question from Kimberly Harrison. It's not a keeping clean question, but it's a question that we've all taken over the last 9 months, which is, after being exposed, how long before you might have symptoms? Now, this isn't either of your area of expertise, but I'm sure you have an answer. If you're not comfortable, please tell me.
So if you've had a high risk exposure, which is, a cumulative 15 minutes or within 6 feet of someone within a 24-hour period, you could potentially have 14 days before you show symptoms. So we have people say, well, I tested negative. I said, well, okay, well, you still have, if they tested negative 2 days, well, you still have 12 days to show symptoms. So the time frame for showing symptoms is usually between the 2 and the 14 days, with most people showing symptoms at 5 to 7.
Yeah, exactly.
And Mark, do you want to add something?
No, that's exactly right. And this is why the Thanksgiving question is so hard, because you could on Tuesday go get, everybody tested, everybody tests negative. And then on Thursday, if they've had an exposure within 14 days of Thursday, they could still become positive before negative doesn't clear.
Testing, right? It's an extremely useful tool, and we need more of it. But it's not useful for some things, Mark, like this, as you're saying.
Right. You have to really think through how the testing is being used. So there's all these rapid tests and antigen tests, and when we use them for screening, say they are like 90. Say that there's like a 3% false positive rate, which sounds great, 97% specificity. But like on a film, for example, they might test 200 people a day. That's 6 people are going to have a false positive every single day they do testing. That doesn't work as a screening tool. So you have to look at each kind of testing tool and ask yourself, what's it for? Some of them have a high sensitivity only when people are symptomatic, and they're not meant for screening. They're meant as a clinical tool, and they're not meant for screening our asymptomatic carriers. So testing is amazing, and it just has to be used in its context for what that tool is. And what are you doing? Are you screening healthy people so they can come to work? Are you taking people who are symptomatic and trying to figure out if they have COVID or the flu or something else? Very different ways to test.
Absolutely. We've got about 6 minutes left. Amber wants to know, is there any special cleaning in the car that should happen? Either of you?
I wouldn't think that, if you had a person of known positivity, you might want to clean your car, but just normal cleaning that you would do every day, I wouldn't recommend anything different.
I'd focus on the high touch surfaces. If you think there's been, someone is positive in your car, a couple different ways you can handle that. You can obviously disinfect things. You can leave the windows down and park it for 72 hours. It will really reduce the amount of virus that has survived. Go park it in the hot sun. That would help a lot. So there are, different ways to think about. But again, as with all surfaces, what is the context of the risk? Has someone been in there, exposed? As someone, they have allergies, they've been coughing, you don't know if they had COVID or not, you're not feeling comfortable. The other side of this is the psychological, like what's going to make you feel comfortable? If you're going to keep you up at night, it's like, oh my gosh, that person was in my car and I don't know, what should I do? Like, by all means, go disinfect it. There's no real downside in that. But really think about the context of what is, as we would think about our own exposures, have I been within 15 minutes and 6 feet? Do that for each of the surfaces. Has this surface been in, contact with someone who's high risk? Like that would tell you if you need to do additional.
What about if you are a Lyft driver or Uber, or you're someone who's taking a Lyft or an Uber? I did that last week and I wasn't sure what to do.
So when I get in a car, just myself, and I have my carbon dioxide monitor with me because I have one, I see even with the air on, the outside air coming into the car, the carbon dioxide goes quite high after a few minutes. So that tells me you're really not getting good ventilation. If you are riding with someone, windows down would help tremendously to reduce the ability of the droplets to concentrate. Because again, it's all about the dose of virus you're exposed to. So windows down and that circulation will keep that from concentrating. How you want to definitely wear a mask. I would wear the best mask I had if I had to get in that car, and I'd make sure the driver's in the mask. Drivers, I would say, are getting exposed. Like they're in an isolated environment for more than 15 minutes. Even if we're all masking, that's a tricky environment.
I see you showed up, Nathan. Do you have something to say, or do you want to read the last question?
Giving like what's called the 2-minute warning there at the end, if you wanted to wrap up here before I close everything out.
Well, first, let's see if we can squeeze in a quick answer to Heather Hansen. She wants to know, since we're talking about disinfecting, what are the best methods of disinfecting surfaces? Monica?
Oh, yeah, just use EPA approved product. Most of your products on the shelves, your Lysol, your bleach, most of the ones that you can buy will disinfect appropriately. In the hospital, we use hospital approved EPA products. UV light is a great source of disinfection as well. We don't all have access to UV light. But yeah, just basic wiping of the high touch surfaces would be a great start at disinfecting.
Okay, Mark?
Yeah, I totally agree. That sounds great.
All right, Ethan?
All right. Well, thank you so much for being here today. Thanks to Dr. Mark Stibich, Monica Pierce-Charlton, and Bonnie. Of course, thank you, Bonnie Petrie, for moderating today. I want to let you know that the slides that Mark and Monica were trying to present earlier this afternoon, they'll email them to us, and we'll be putting them up on our website for this story so that you can see some of the charts and other things that they may have been referring to. But I think that we got the gist of the conversation through their intelligent speech today. So thank you so much for that. We want to thank San Antonio Vascular and Endovascular Clinic, Xenex Disinfection Services, for their support of Think Science today. And again, yes, this presentation will be on our website later on next week so that you can share it with a friend. Our next Think Science discussion will be coming up in February, and I want to wish all of you, our presenters, and those here on the line watching today, a safe and happy Thanksgiving. Thank you very much for being here.
Thank you guys as well. Everybody. Thank you. Bye.
Bye-bye.